Good morning. I think we're ready to get started. So before we get started, we just have a couple of housekeeping items. So just as there's going to be a whole lot of people participating, and so if we can ask you, unless you're a presenter, to please keep your camera off. And to know that microphones are going to be disabled during the presentation, but if you have questions, you can absolutely put them in the meeting chat, and we will circle back to those. The way we're going to have the session run is each of our panelists will speak briefly, and then we'll get into the discussion. And so if you have question and answer, or if you have questions that you'd like them to answer after kind of the initial part of the panel discussion, then you'll be able to use the raise hand feature, and we'll enable your microphone so that you can ask questions. And also, just so that everybody's aware, the panel's being recorded. I think you see the little message at the top saying, by joining, you're giving consent for the meeting to be recorded. So just know that that is that. And so I think with that, we are ready to get started. So this panel discussion today is about using data to drive better health outcomes. And so really within that, what we're looking at is how big the opportunity is to use not just clinical data, but all kinds of data in order to come up with creative solutions and understand the complexity of issues that are driving big health problems, and be able to use those data across different sectors, across different health indicators, across different social factors, to be able to really get innovative about advancing health equity and advancing health outcomes. So we've got three fabulous panelists who are all bringing a really unique lens to the conversation. So I will introduce them, and then we'll get started. So first we have John Bostick, who is the CEO and founder of Hive Networks. And then we have Stacey Brooks, the Equity, Diversity, and Inclusion Reskill Strategy Advisor for Humana, Inc. And then Dr. Nirav Shah, who is a senior scholar at Stanford's University Clinical Excellence Research Center, and also the CMO of Sharecare. And so we're actually going to start the discussion with Dr. Shah.
Well, thank you so much. It's a pleasure to be here and join you today. I'm excited to speak with you and learn from you as well. And I'd like to start by suggesting that today we actually have a perfectly designed $4 trillion healthcare delivery system in the US. It's perfectly designed to deliver more and more health care. It's not designed to deliver more and more health. But what is it we want? More health. And we are now, I believe, at an inflection point where technology, including AI and automation, which is not a silver bullet, but are unlocking immense value. And COVID has really shown us what's possible, or at least scratched the surface of what's possible. We have a digital divide in the United States, and that's going to be a big part of the problem. The digital divide exists for broadband access in the home. But if you look at the data, the digital divide does not exist for home smartphone use. Almost every family in America now has at least a smartphone with a cellular plan. Pew Research study done in 2019 showed that for across the races, the rate was about 80% of homes had at least one smartphone with a cellular plan. So if you think about what we can do in the near future, before this administration's home broadband use rolls out, over the next 3 years, we can actually focus on using the smartphone to really change the nature of work and change how healthcare is delivered. And that future of healthcare is digital, mobile, virtual, continuous, remote, asynchronous, and objective. And I'm not going to get into all of those right away, but the points are we can do things that we never even imagined 3 years ago, 2 years ago, even a year ago. At my own university at Stanford, we went from 0 to 75% remote visits, video visits in primary care in 3 weeks. Now, the pendulum has swung back as COVID has eased up a bit, and we're going back to in-person. But the reality is that probably over 50% of primary care visits can be done asynchronously and or remotely. That's a fundamental shift from just a year ago. And what it means is that we can unlock new futures, unlock access to care in different ways, and create opportunities for different skill sets and different workers across America to participate in healthcare delivery. And ultimately that will lead to us delivering more and more health. I'll stop there because I know I want to leave a lot of time for the Q&A. Thank you very much.
Thank you, Dr. Shah. And now we'll have Stacey Brooks.
Well, thank you. And I appreciate everyone's time in joining the Future of Work conference for these 2 days. It's inspiring. And, you know, when I saw the topic that we were going to cover, you know, I was wondering, oh, well, why do they want to talk to me about this? You know, I'm a talent developer, and then I wanted to see how we wanted this conversation to go. And so Dr. Shah really gave me a really nice segue because he talks about, you know, the digital divide. And you know, that is something that, you know, Humana was aware of before, you know, 2020 really accelerated the context of that. And so, you know, one of the origins of, you know, the work that I do is meant to address that digital divide through people, right? And through creating connections from one side to the other side of that digital divide. And so when it comes to what are the origins of the program that I have the pleasure of running, that's called the Data Science Rotation Program, it's meant to address the digital divide, but then also some of the things that we saw last year that accelerated that as it relates to health equity gaps. So we saw, you know, the pandemic really demonstrate just how fragile we are as a society relative to, you know, some of the domains in our commerce space. Industries really disrupted. We saw a lot of the devastating impacts of COVID itself as it relates to disparities of health relative to people of color, Hispanics, Asians, people that are on the front line. And we saw this at the same time that we were seeing all of this economic disruption, people losing their jobs. And going back to that notion of the digital divide, one of our leaders, Roger Kood, who is a keynote of this conference, began a few years ago to say, what are the jobs of the future? What do we need? What does Humana need? You know, our role, our mandate is to close health equity gaps, right? To make people healthier. And he looked at what are the emerging, you know, talent, skills, capabilities that are going to allow us to do that. And he began to see a number of things and making connections. One was, what are the new roles that we are going to have here as a company? What is our, you know, our talent base? What is our draw as a city? You know, what do we need to put in place in order to make this a place for digital analytics and insights that will help us close health equity gaps? And this community strategy, the strategy that he runs today, community and digital engagement, gave birth to this idea that was accelerated last year. And so what we're doing is we're partnering with organizations that allow us to do a couple of things. One is reskill people that have been disrupted totally in their roles, and then upskill. And how do those two different strategies help us as a company to close health equity gaps with data? Well, when we're looking at what I do, I work in the digital health and analytics section of Humana. We're doing all of this innovation, creating all of these capabilities that are literally making it more efficient for our associates to serve members. At the same time, some of the roles that we're doing in the digital space are automating some of the things that we're seeing in, let's call it the analog space, for a lack of a better term. Well, my leaders are sensitive and aware of that. And so we wanted to use that as an opportunity. So what the strategy has begun to become is we're going to leverage our wonderful talent base and devise a strategy to create that digital analytical capability within our own company, right? Leveraging the great talents and insights and experiences of the folks that we have here and creating that bridge across the digital tech divide. In the community, we are creating different entry points for members of the community to get across that digital tech divide and also come into our company to contribute to our strategy. How does that help close health equity gaps? Well, right now we have a team of folks in Humana that are creating member experiences, creating journeys. All of those things culminate to creating health outcomes for our members. By bringing in talent from the community, by leveraging the talent that we have in our company, we're able to accelerate and make our strategy more efficient, because we have people that have been with Humana for 8, 15 years that are now gaining new skills and capabilities that can contribute to our strategy. They know our members, they know our community, and they know where the gaps are. Members in the community, they know the issues in the community that create barriers to health. They come, as they learn these new skills and capabilities, they're able to really accelerate and inject that insight into our strategy. So it's a people approach. It's an access approach to really developing an innovative way of gaining new insights from different places that allow Humana to have a pinpoint focus in these different communities with these different groups. And all of that amounts to closing health equity gaps. I don't know how long I took, but similar to Dr. Shah, I want to make sure that I'm not going too long and that we have time for a fruitful discussion. I could go on and on about this. I'm very passionate about it.
We'll ask you some questions here in a minute. Thanks, Stacy. All right, John, it's you.
Thanks very much, Monica. It's interesting is I kind of think of what Nirav's presenting and then what Stacy just talked about. And being from Cincinnati, I think of a Skyline chili 3 ways because I'm the extra third way. And it all goes together and the ingredients become really, really tasty. And so what I'm going to talk about today is really the problems that we as humans, individually, our families, our friends, our neighbors, our work colleagues, we all know people that have Crohn's and colitis. We know people that have a child with potentially a genetic heart disease or a kid that had a resection of a colon where now they're wearing an ostomy bag. And the list goes on. We all have these things that we live with in our lives with all these acute care and chronic care issues and rare diseases. And we ask ourselves, how can we really have a better focus on improvement of the patient outcome? How can we bring that together? And it is potentially the internet a new superhighway to do that, and is potentially the access to data, and data not only in the electronic medical record, but also data that comes from patients like us that are living every day that we can perhaps put into Nirav's iPhone application or have the data analytics folks that Stacy can identify for trends and asking for more data. And so what the real opportunity is here is every healthcare institution around the world is faced with this concept of how do you get a breakthrough in outcomes? Nobody can afford it. Everyone has this problem. Even though we see that in the US, it's the same problem in Sweden, as in Somalia, as in San Francisco, our own country. And where we need a tactical solution, most of these solutions in today's market end up to be really tactical, not strategic, I guess is what I'm saying. And so some doctors may be collaborating with other doctors. But if it was strategic, of course, they would include families and the data they have, researchers and the data they have, and other caregivers and the data they have. ideally the entire network. And the internet has two things. Number one, it has nanoseconds to update. Number two, globally distributed everywhere. And so to be sure, it's really not been a traditional strategic solution to boost outcomes, but now with the data that we have access to and the ability to propagate that into a single data storage device, and so for us to be able to look at that data in a unique fashion from the data scientists and look at it from adding data just on a daily basis, we have opportunities to create new breakthroughs as a result of that. And so let me tell you a short story about that. So 7 teenage girls, 15-year-olds, that all had Crohn's disease, all wearing ostomy bags, which I think most of you know what an ostomy bag is. They want to do one thing in the summertime, and that's, how do I wear a bikini and be at the swimming pool with my friends and just have a normal life, just be a teenager. And so they got together. Nobody asked them to get together. No one taught them to get together, but as they joined a working community around inflammatory bowel disease, they learned that they can start sharing ideas and sharing it via the internet, and then being able to measure those ideas in kind of a scientific gauntlet and do it with some more formality, if you will, and continue to add ideas on it. And so then I look at body type, cut a bikini, the cloth of the bikinis, what kind of cover do I have for that ostomy bag? And so what they come out with is an intervention to share with others. And so by posting the best practices of how to address and wear that bikini with my ostomy bag, so they can be with their friends and not worry about their medical device on their body. They posted it, and 7,000 other young teenage girls got it, and it started to add more of their ideas on it. And so what we've figured out is that you can start crowdsourcing this data. And I give you the example of just a patient. We all can think about opportunities to share that data, just like we want to share stuff on Craigslist, who's the best plumber I want, or what's the best restaurant I can go to the other social network site. And we can do all this outside of healthcare. Well, why can't we do it with healthcare is the question we ask ourselves. And with today's internet and today's opportunities for the scientific analysis of the data and ideas of putting that data in ubiquitously in an easier fashion, we can accomplish more. I think Bill Gates is the one that said, everyone always over predicts the next year, but we really under predict the next 3 or 4 or 5 years. And I think, like Nirav has says, we're at this new era of leveraging all these devices and the internet and people that get retrained. We have this convergence of all these resources to have a new era of focusing on 3 things: is providing the quality of life that everybody deserves, everybody. Then we increase the speed towards improved outcomes, not only the social example I gave you with the young ladies with the bikinis, but also doctor to doctor, doctor to researcher, researcher to patient, patient to researcher, and really take down the barriers of this model. And then the last thing is make healthcare more affordable. And we do that by improving the outcomes and reducing the number of emergency visits that a child may have or an adult may have on dehydration due to a Crohn's disease, as an example. And so we have such a large opportunity. There's 7,000 diseases in mankind and humankind, and we now have an opportunity to really start to, one by one, scientifically, via the crowdsourced data, go after each one of these in a more clever fashion more than ever. And so that's really the end of my presentation from the kickoff here. And again, I'd like to open it up back to Monica for discussion purposes.
Great, thanks, John. So listening to all 3 of you kind of come at this from different angles, and the skyline chili analogy is absolutely my favorite. But
I'm getting hungry right now. So
I know exactly what you're talking about. So a lot of what you're talking, what collectively the 3 of you were talking about, is creating ways to compile data, to make data accessible to people who need to have access to it, in ways that are useful, and then looking at some of the shift of how the accessibility and utility of the data changes the context that we're in when we talk about healthcare. And so I'm really interested to hear from you guys, because there's a lot of, in that shift, what does that look like? And so, John, I'm going to start with a question for you, because you were talking about crowdsourcing clinical data, which sounds it sounds interesting, but also, right, like then it raises a lot of questions. So what would a network like that look like in real life if we're talking about healthcare, and how does that change the roles of the people who are involved?
Yeah, it's an interesting question you have, Monica. It's if we go back to the concept of the acronym HIPAA, and I think we all know HIPAA as an acronym. The P in HIPAA stands for portability, and there's probably two meanings of the word portability here. The original meaning was sustaining social and legal support for healthcare as an individual need for each of us as Americans. Okay, so the portability of our healthcare record, our ability to be able to have our healthcare there. But the second definition, I think, I go back to the dictionary term, and that's the ability to be, portability is the ability to be easily carried or moved, and the ability for us to move that data to be transferred from one machine or system to another becomes that portability. That's the leverage factor right here. And so when we look at the data, we do have clinical data, we have social data, we have behavioral data. Behavioral data for Crohn's disease could be number of glasses of water you drink per day, number of hours of sleep you had last night, or perhaps what you ate yesterday. But when we have all these pieces of data and then add genetic data, because that's the fourth frontier, if you will, okay, we have all these data ports. If we start connecting the clinical data together in a crowdsourced fashion, there are legal hurdles we have to address. A business associates agreement is the tool within HIPAA that you have. So we've been able to gather, using my example of Crohn's and colitis, the inflammatory bowel disease, gather 110 clinical care sites together. So 110 different hospital systems. So that means 110 BAAs. That actually means 110 lawyers, okay? And getting everybody together and being able to be comfortable about using that data towards improvement, using it towards research, having the right governance model for that data, adding the social data, the behavioral data. It is a complex problem to solve, but we've proven that it's solvable, it's scalable, and it's spreadable.
Stacy, do you or Dr. Shah have anything that you want to add to that?
Well, I come to it from the standpoint of, all of that information, comes through people. And, when we think about, I look at there's the data, but then from the standpoint of, a group like I work with, we have, an enterprise data and analytics organization. We do, machine learning and augmented intelligence. We do analytics platforms as a service. We do data governance and stewardship. And the conversations that we have are, the balance between, all of the data, access to the right data, making sure that we're thinking about, okay, well, we're also curating. Curation, means that there's intentionality behind it, and it's not neutral. And so from the standpoint of, bringing in people from, our own organization that, have empathy for our members, have empathy for, people of color, people who are marginalized, sometimes people that have ability or disability challenges, right? It's the people that are able to be able to see, as it relates to the capabilities, but also the things that we have to heed and be careful with as it relates to the leveraging of this data.
I'll add a little. I think it's actually a false choice between privacy and personalization today. With data, we have new technologies such as edge computing, federated learning, zero trust environments that actually can solve these problems today. I'll give an example of a recently published study that I did here at Sharecare around asthma and allergy. Today, with the smartphone, you can create an AI predictive model that will tell an individual their risk of having allergies on any given day based on the local pollen counts, based on the humidity, based on the weather, based on other factors. that is pretty good. So in the morning, so if you have on your phone a predictive model that lives on the phone, and then based on your GPS collects where you walk. If you walk to work through the city streets versus you walk to work through a park, and on the day that you walk through the park, it collects your symptom score and you have worse symptoms. Over time, that AI predictive model gets smarter. And all that data of where you walked, what symptoms you have, live on your phone. Those data don't have to leave your phone, but the predictive model gets smarter on your phone. Ultimately, the learnings from your data, the predictive model itself, the beta coefficients or tensors or whatever you want to call it, go back to the cloud. And the mothership predictive model gets smarter based on the thousands of people who are walking around recording their symptoms. None of the data leave your phone. It protects privacy fully, and at the same time, everyone crowdsources benefits from the learnings of everyone else. That's available today. So federated learning, edge computing, zero trust environments are one example of today's technologies that get past HIPAA and allow us to unlock the power of big data while not having Big Brother watching.
So I think that's really interesting, and I definitely am curious to hear you guys then talk about, so Dr. Shah, you answered actually a question that I had around, you know, if it's just on your phone, then how is everybody benefiting from everybody else's data? Because that's a lot of what we've been talking about is, right, that crowdsourcing. So you totally answered that question. I think one of the pieces then is within, so what you said about our healthcare system, right? It's perfectly designed to deliver more healthcare. So how do we harness that to deliver more health? I'm gonna borrow that one in the future. The way that our healthcare system is designed, right, is fragmented, and it is proprietary, right? And so we're looking at how do we for different components of the healthcare system take the data that we have access to and use it to improve the outcomes for our people, because then that means that we're doing better, right? And so if we're talking about, in some ways, and I'm going to throw this out there, I'm not sure if it's the same, if it means the same thing in your science as it does in mine, but kind of the democratization of data. How does that fit in with the way that our healthcare system works, and then how do we use that?
Well, I think John has painted a future of crowdsourcing that is a vision that we all want to get to. And I think the technologies will allow us to do that. What he's built up at Hive and what they've been doing across these amazing networks of networks, frankly, with children's health across rare diseases allows us to not have to rely on the hospital owning a data or a health plan owning a data. It's you who own the data, and you decide as an equal partner at the table with the doctors, with the researchers, with administrators, how your data gets used for insight, for discovery, for research. That's the real, that's the future, that's now. And we are now seeing that those silos of people hoarding data, it's your data as an individual. It's not the hospital's data. And that fundamental shift in ownership allows patients to really come to the front. If you see now, CMS is paying for and only paying for certain outcomes if you collect patient-reported outcomes. For example, with certain orthopedic procedures, if you do not report from a patient how they're doing, you're not going to get paid the full amount. Of course, that's what we want. We don't want just dry clinical measures that happen once every 6 months. We want real-time, continuous patient-reported outcomes on how they're doing with their disease or how they're doing with their condition. That's that locus of control shift is happening, and that's going to make a lot of business models obsolete very quickly.
So Stacy, I would be curious your perspective then, looking at an organization like Humana that is so vast, right, that serves people all across the country and has historically been collecting a certain kind of I guess, clinical kinds of data, but now is integrating different kinds of data into that. Like, what does that look like in terms of when you have developed expertise in your company? And I know this is the area that you're in, looking at upskilling and reskilling, to account for data that are very different than what the analytics have historically looked like for a healthcare company.
Yeah, and so, what I begin to think about when you ask that question is, one, our strategy as far as, our members, the places that we have, carved out as far as our markets, and then, our CEO, I think it was around 2013, 2014, really made a public intentional shift to like, data is going to be the kind of the fuel that really accelerates how we do, the project of becoming a health partner for life. It is that part of it that is making it possible for us to shift from health insurance heavy to health care heavy, and then really creating more delightful health experiences within the healthcare domain. So, really doubling down on our primary care and really making it easier for providers to do value-based care, to really check up on their patients, and really to have more of that facing, that communication relationship, rather than all of the clicks and things that, generally have to happen after a patient visit. So it's our application of data and analytics to really become a better partner to providers, and with the ultimate goal of being better at showing up for our members. And so that's one of the ways that I see that. But also from, an equity, diversity, and inclusion standpoint, thinking about, representation, right? You have that picture of Tommy Smith behind you, if I can use that as a prop from the '68 Olympics. You have to ask, well, why was he doing that, right? That's about visibility and representation. And while we're talking about all of the data, people have to be in the room. Intentionality, empathy, visibility, all of those things allow us to wield this data in ways that really allow it, that really drive those delightful, meaningful experiences that also don't do harm.
I love your characterization of delightful healthcare experiences. I don't think I've ever heard anybody talk about it that way.
We can do it.
And if I might just key off of what Stacy just said right there, and that there's several different things that's going through my head at the same time, but I think when we've crowdsourced data through all the research and the efforts of focusing on individual data lakes by disease, by chronic condition, and using Sharecare, Nirav's model, to add more data in ubiquitously, that's smart data that's already had some processing to it through the artificial intelligence engines they have. Then I come back and say, but wait, we haven't got the social determinants data in that system. Why is that? It's because that data is not normal in the electronic medical record. It's not normal within the data inputs. And so I think over the last 12 months, especially, the world now acknowledges that we've got to get the social determinant data in there to then look at access, look at inclusion, and really study this. We're doing a project right now in South Florida for dyslexia, and providing the concept of frankly, kids with dyslexia with higher economic means get a lot of help. Kids that don't have that economic means, they don't get any help. In fact, they don't even get the analysis. And so all of a sudden, a young man grows up and they're 18, 19 years old, dyslexia, they're unproductive in society because we did not serve them properly. And we've got to then take, and I can replicate that example over all the different diseases and conditions we work with, and something as simple as kidney transplant. We have a new program where we're now measuring the social determinants of all the kids with end of stage renal disease or in need of a kidney transplant. So we got to get down to the very granular part, and then take that data, we de-identify it, we put it in crowdsourced engine, but we don't forget about that social determinant measurements aspect of it. We've also done the same kind of model for underserved moms in the state of Ohio, where we now know pre-elective term delivery for underserved moms has been rampant. We've now taken the scientific model that we support through the improvement process, and we've taken that pre-elective term delivery down to basically zero in Ohio at 52 maternity centers in Ohio. I mean, these are big lifts, but they really are possible. The other side I want to mention is I was with the late Dr. Peter Drucker, the management science professor, and I had a coaching session by him, and this is 30 years ago, so I've been working on data for a long time, and I said to Dr. Drucker, can we ever solve the metadata situation where we have the real measures of this data? And he looks at me and says, of course not. And I'm like, wow, of course not? And he said, no. He says, mankind, we're carnivores. In the past, we fought with knives and daggers and clubs. In the future, we'll fight with data. That was very, very, very interesting, because as we look at this model and talk about healthcare data, we got to not kid ourselves. And there's going to be a large number of battles among mankind, among humankind, about data. And we need to be able to transparently speak about those fights and then figure out how to eliminate them.
So I'm coming into this conversation as a social scientist. And so the conversation about the kinds of data, I do community-based research. And so social determinants of health data, that's my jam, right? But I also know, because I work in this area, how loose our ability is to measure, right? When we talk about social determinants of health, we don't have standardized definitions of what the indicator is necessarily, right? Or of what the best measure of that indicator is. And here's a challenge that I deal with on my side as a researcher who's putting this in. And so I don't know if you guys have insight into this in the work that you're doing. When we talk about the kinds of determinants that are happening beyond individuals, right? So we're talking about social determinants, or we're talking about organizational determinants, or we're talking about community level determinants. They exist beyond the individuals, but a lot of what we do in our data is measure individuals and then just aggregate it up to different levels and say that's the measure. I think that there is something in there around the story that we're telling, right? If we're not measuring, if we don't know how to measure something directly, are we interpreting it well to be able to actually do the most right thing in terms of what gets us a better outcome? And so I'm curious kind of how each of you is dealing with that or sees that in the work that you're doing.
I'll just point people to two quick resources. One is xy.ai. Imagine having a fleet of satellites around the world looking down at you, and you can draw a map around any part of America, and it'll tell you all of the social determinants that you're interested in based on multiple data sets aggregated. It looks at the buildings, how dense is the residential neighborhoods? What are the food deserts? All of these things, that's available today. Look at the Community Well-Being Index done by Boston University's School of Public Health. They collect 600 different measures across every community in America, which includes things like bikeability indices and other things. So there's no limit. We have all of the data. What we lack is imagination in applying it to real problems today.
I'm going to give them some space, because then I'm going to follow up, because I only kind of agree with you.
Fair enough.
I was going to go last on this question because I think that what we're trying to talk about is, well, we have all this data. We know these things at the individual level. And I think that we also know that structural and institutional racism exists, right? And we also know that is, kind of by design, not by intention, by individual intention, but like it's by design. It's not an accident that we find this, right? Because you can go to whatever city you want to and look at it structurally, and you're going to find the same dynamic. And so, as it relates to that reality, right? That's why I think that as it relates to the incremental data itself, right? It's not neutral. It exists in a cultural context. The aggregation of that and the curation of that, that's not neutral. It happens in a cultural context, but all of this other stuff is happening too. So I feel like what we're acknowledging is the vigilance, the continual vigilance that it is required in order to continue to evolve and utilize these enormously powerful capabilities, but to know that some of the ways that we're applying it work and they do certain things, but there are more intimate spaces that we might need to have deeper, more thoughtful, slower consideration with what we're doing in those spaces.
John, did you want to add? Oh, go ahead.
I was just going to say there's a fundamental general lack of understanding of data in the context of what's available, how it's available, what legal hurdles that people by design, as Stacy said, have put up to block people from using that data. And I think you got to go back to the structural concepts of there's 4 types of data: unstructured internal data, structured internal data, external structured data, external unstructured data. When you start looking at that 2x2 box, traditional corporate America has always looked at structured internal data. And that's been their 100% of their world up until just a few years ago. Now we're looking at these 4 different sets of data. And so when we start adding data in and enriching that data and developing tools to read that data and develop artificial models, intelligence models on that data, we can start to really propagate that. But I would tell you what's going to hold us back is for me today to take clinical data and try to go get public data that's population management data based by state, if you will, or by county or city by city. They won't let you at that data. They block you from that data. And I'm making a generalization. However, what you'll find is that they'll have reasons by they say, well, you're not authorized to use that data. And these are just miniature roadblocks that we have to be prepared for, develop ways of getting over.
Yes, I think part of that is also in the accuracy of the data. So yes, the ability to use, but when you're talking also about then bringing in data sourced from different places, and even in the democratization of that data, you're also talking about really subjective kinds of measures coming in, right? So back to the example of walking through the park versus walking through the city, right? And collecting, like, what are your symptoms or how do you feel? Well, how do you feel? I feel good. I feel stuffy. I feel, but what does that mean? And what is my definition of that compared to yours, compared to everybody else's? And when we're talking about crowdsourcing, then, right, like individual people who are sourcing the data aren't necessarily measurement specialists. And we can give them scales to try to approximate that, right? But that can be a challenge. I do want to come back, though, Dr. Shah, to the point that you made about, kind of the satellites that can zoom in and tell you very specifically about social determinants. And that's really cool, and I did not know that, and so now I'm going to be looking into that. However, as a social scientist, one of the things that I would argue that isn't captured that way is the social part.
Yeah.
And so when you talk about, and kind of going back to what Stacy was talking about, when you talk about power and how power is used in creating structures, and what those structures are designed to do. You can capture the outcomes of it. In some ways, you can capture the processes of it, but the context itself isn't capturable by an external observation. I think that's part of it. And then I think the other piece of it, and this ties back into, people capturing their own data, is the experience of it, right? And so from a social scientist perspective, I am not a positivist. I believe in the value of empirical data, absolutely, but I think that there are also very meaningful, important indicators that are not directly observable. And so then what does that look like, and how do we account for the context, knowing how important the context is to what those outcomes are?
So I disagree here. I think that there is so much more that we haven't even explored. I'll give you a real example. Today, you can get hearing aids that can capture in real time a continuous score of social isolation, because it listens to and knows who's speaking to you, how many different people are speaking to you, how many words you're saying in a given day, and based on GPS, how many locations you're in. So social isolation and loneliness that used to be measured by 4-question UCLA scales or other things are now being measured in much better ways by real devices that are ambient intelligence. They're on, they're continuous, they work in the background, and they can in real time tell whoever it matters, whether it's your health plan, your doctor, or someone else, that you're at real risk because something has changed. You used to have 50 visitors and you used to visit 10 places in a week, and now that's gone down to 1 because of COVID, and you have one person speaking to you twice a week. Those kinds of data can be built into your phone, into your hearing aid, into any devices today. And they cost this much because it's all electrons. And if we were able to do this in real time with a pulse of social isolation, imagine how we could direct our resources, which are very limited, to those at highest risk. That's the kind of ability we have today with technology. We aren't using it at scale, but there's no reason we couldn't, because it's available.
So, question, in I guess in the spirit of Monica's disagreement here, that's when the panel gets fun for me. So I don't use the team's backgrounds because I don't like observing the racism of it. Right, when I move around, right, I don't enjoy the way that the background screen does to my skin and my appearance when I'm on. So I just use my own background, and so we see the many examples where you think about the associate who was kind of looking at how pictures were crowdsourced, and he found that friends of his who are African American were tagged as gorillas. And he said, hey, Twitter, hey, you messed up. My friends aren't gorillas, right? So people are kind of tagging this information, right? So the information is, the data is one thing. So let's say we have a zip code, right? We have a zip code. Let's say the zip code is, the Russell neighborhood in West Louisville, right? And so there are a lot of, that's just for some people, that might be a neutral thing. It's just a place on a map. But we also can begin to learn all of these other layers about the experiences and the health outlooks of the people within this zip code. And we could also draw assumptions and conclusions about this place as well. So, how do you engage with some of those things, and how you might have a discrete piece of data like a zip code that might seem neutral, but it can be layered with so much meaning and other stuff.
And that's why, Stacy, I talked about this metadata dictionary concept of what the data means, what it means to be accurate, and everyone has a different slight variation of that for their own, I'll call it political advantage, or their own design, as you used the word earlier, which I fully agree with. And so when you look at this model and say, how do you take this, and there's always two approaches to solving a problem: whole to part, part to whole, top down, bottom up, right? And I truly believe what Nirav said about the appliance for your ear. has got to be a bottom-up movement. It can't be a top-down. I think that what you're talking about, Stacy, I think is a bottom-up movement. What I'm doing is a bottom-up movement, and it's very disruptive. And there's people that are going to want to see us fail in this kind of context. At the same time, if all of us are doing this all at the same time, there's no possibility of failure. There'll be somewhat successful outcomes and some very successful outcomes and some failure. But the train's left the station, man, and data is going to be democratized, like what Monica said. Okay.
Mm-hmm.
Yeah, and I think that definitely is one of the major points that you guys have raised. Is we have it. It's there. It exists, and the uses for it are only going to continue to grow. And I think that's kind of the part of how do we make sure that that use is for social good. And what does that look like? So I want to see if there are questions from any of our attendees, as we've got about 10 minutes left, and we've asked a couple of questions that have come out of the chat along the way, or you guys have answered them even without being asked. And so just want to see if there are questions coming out of the audience. All right. So Eric, should we go ahead and move to the Q&A?
I think so. We have one other question there from Teresa, but otherwise, yeah, I think we can move to Q&A after that one. Yeah.
Okay. So the question is, how do we think the alignment to value-based care will get launched?
Let me just start that theme by saying we, as a disease by disease, condition by condition, we have to have relentless focus on the outcome. And by what the definition of that outcome is, it's got to be a crowdsourced, aligned definition of the outcome. And that's a health thing, not a healthcare thing, like Nirav said.
Yeah. Totally agree. We're having a conversation about this with the team this morning. Really, them discovering how what they're doing is contributing to the progress of helping providers with that project of either whether it's transitioning from volume-based to value-based or enhancing their value-based platform that they have right now.
Yeah, I think so many vectors point toward what the promise of value-based care will give to us. We've talked about it for the last 20 years, but we've seen a lot of movement in the past year. We've moved from the specialty-based practice of medicine. I treat the pancreas, I treat the heart, I treat to the whole person approach. We understand now that the brain is connected to the body and that mental health affects costs and quality and everything for every condition. And so to the extent that we're moving from fee for service to global capitation, and you have to pay attention to the whole individual, what their goals are, how they want to live their life, what their context is, all of that bodes very well for us as humanity, as individuals in our healthcare system. And so I'm an optimist, but I'm very hopeful that we're actually closer to that tipping point toward value-based care.
Yeah, and so let me make a generalist statement. If I look at the amount of money that's being spent on brick and mortar, improving the distribution channels of hospital systems one after another versus their same investment on this virtual thing called data, it's kind of weird, isn't it?
Do you see it changing? Because it seems like the last year has definitely shifted some perspective there.
Well, if we look at the lessons learned from the retail industry, from the manufacturing industry, from the financial services industry, where a company called Stripe can come out and become the king of the mountain, if you will, I think that the lessons learned in other industries are this is coming, and it's maybe a tsunami. So if you have the ability to do something now, I probably would.
Yeah, I second that. This is a trend. I think John kind of retitled our panel discussion to democratization of data. The train is left. It's not coming back. Or it's a long title, but through the people that we are connecting in different ways that are going to be bringing their ideas, and they're going to be thinking about, okay, well, how can we use these data to solve these problems? How can we innovate, and how can I contribute to that project? And then all of the other different, innovations and insights that come out of this. And then to the point, there are going to be some contentious, highly debated conversations, and we need to have those too, right? And for some organizations, the work that they're having to do today is kind of strengthening themselves, steeling themselves, so that they can have that courageous conversation, so that they can get on board with this project.
All right, well, so we will open the floor to questions. If you have a question that you would like to ask, you can use the raise hand feature, and then Eric will unmute you so that you can ask your question. All right, one of the questions coming in on the chat, how long do you think it'll take to crowdsourcing data with standardized HIPAA laws for global uses for researchers and doctors? So like, how long is it going to take before we get those 110 lawyers, to the power of 100?
Yeah, so a couple things before, when you talk about value-based care in the mental health area, I wanted to make one statement before I answer that statement, and that is using devices like what Nirav was talking about the mental health and artificial intelligence. Every disease condition, especially the chronic conditions like a Crohn's disease or epilepsy, or just you had an organ transplant, whether you're adult or you're young, everyone has behavioral health challenges. And so we need to include a behavioral health module in every single care model. And I think Nirav's got some ideas on that I think are just breakthrough kind of models. Now go back to the crowdsourcing of data. We have a new legal center at Duke University started by Keith Pecoro, who used to be Berkman Klein Center at Harvard doing the same data governance model to establish better data governance practices at scale. And it's really interesting. And so you ought to check out what Keith is doing, Keith Pecoro, because there is a concept of a super BAA, a way to then have hospitals feel comfortable to make sure that they don't get they don't get sued, or they don't have to pay huge economic penalties on the data side if we have a data breach. And we need to protect from the data breach by encryption at rest and encryption in movement. We have the technology to really secure the data down. It goes into how the data is being used. That's probably a bottom-up movement versus a top-down movement for now. It may get legislated more from a federal basis at some point in time. We'll see.
Yeah, I'll just quickly add, zero trust is a really interesting technology that exists now that is not widespread in healthcare yet, but there's our old systems that allowed for the Twitter breaks where you get into past the perimeter and once you're inside the system, whether you're in the Slack channels or any part of the technology of a company, you can go anywhere unguarded. Zero trust means there's gates everywhere, there's rules of engagement, you can't get in one place. Think of that perimeter defense, which has been used since the 11th century in castles. Now that individual data element has a perimeter around it. And the rules of how you move it along, who has access, when they have access, all of that exists today. That kind of approach is going to first help things. The second is that federated learning approach. I talked about individuals with data on their phone. That also works with Humana having data on their servers. Someone comes in, the federated learning AI model comes in and learns inside the walled garden of Humana. No data can ever leave Humana, but the learnings go out. Humana continues to own the IP and all of the relationships there. That same model can go and learn from 10 other health plans. Everyone owns a piece of the vision of the value because of the relative IP that they've contributed to the model, but the data stays secure and safe in their own servers. That also gets past the HIPAA concerns because the data isn't moving anywhere.
Really, really interesting. Well, I hate to say it, but our time is up. I I know we could keep having this conversation all afternoon. Thank you guys for what you bring to the conversation. I've definitely learned a lot. Just, you guys coming at it from different angles. So I appreciate that. I think that there are lots of good things to both look forward to or anticipate happening or get involved in the happening. Like you said, the train's left the station and right. And so we got to figure out how to make it work well for everybody. So I appreciate y'all's insight. I'm going to ask Eric, is there any wrap up thing? I did not ask that before. Sorry.
Thank you all so much.
All right, so thank you all so much for coming. Hopefully you got as much out of this as I did. Thanks to our panelists, and we hope you have a good afternoon.
And thanks to our moderator.
Thanks, everyone.
Yeah, thanks very much, Monica. Take care. Bye-bye.
Thanks.